Thank you, Dr. Schnitt. So now I would like to invite Dr. Armando Giuliano to the stage to discuss margin width and local recurrence.
Well, it's interesting. Dr. Schnitt could have used my slides, and as I sat there, I realized it's because this is a clinical pathologic problem. We as surgeons have to understand what the pathologist is doing and what to do with the information they give us. And I'd like to show you how I interpret that and also how confused this literature is, and it really doesn't have to be. Well, I think there's general agreement that tumor transected is positive and no agreement of what is negative, as we've heard. Never has margin width received more attention. There are great efforts to expand margins, and we know now that margin assessment is difficult. And this is important because we have to weigh cosmesis with recurrence, with reoperation. And when you ask surgeons or radiation, this is a radiation oncologist, what a definition of negative margin is, you get tremendous variation. But interestingly, the width of an acceptable margin varies with the experience of the surgeon. The more experienced surgeons accept less wide margins. I love guidelines because I look at them and I wonder exactly where they get this information. These are some guidelines, and they're telling us what the recommended margins are, and it cannot be at all defended. I'm looking at Lorraine Taffer, and I remember many years ago, she called me representing the American Society of Breast Surgeons and said, gee, how many cases you think you have to do to know how to do a sentinel node? And I had my feet up on my desk, I scratched my head, and I said, Lorraine, 20 or 25, and that became biblical, 20 to 25. No data, so that was a guideline, and that's how I think guidelines are made. What about re-excision rates? How often do we go back? Well, if it's at Inc., 84% or 90% go back, and as you get away from the tumor, fewer people will re-excise. I'd like to meet the ones who are re-excising at greater than a centimeter, but the re-excision varies with the width of the margin. And if you believe a positive margin is bad, does the tumor know if it's up or down or east or west? So if you really believe that, how can so many surgeons not excise anterior-posterior margins? What happened to my lens zoom? It's interesting also that the positive margins rate varies only slightly with the definition of a negative margin. Can we get rid of that thing? The positive margin rate is around 30% if you define it as greater than 5 millimeters, and it's about 35% if you define it as greater than 1 millimeter, and there's not a tremendous amount of variation based on the definition of a positive margin. And we heard just some of the technical factors. I'd like to show you them from a surgeon's point of view. Remember, all tissue shrinks in formaldehyde, so if they say it's a 2 millimeter margin, it was really about 3. Sampling technique we've heard about, irregular surfaces with ink running into the surface, and crush. I recently changed institutions, and all of a sudden I was getting so many positive margins, and I wondered what was happening to me. You know, is this commute killing me? And I realized that the way they were reporting the specimen and how they were handling it was very different than where I had been for 20 years. So I actually started to take a trip with my specimen and see how do they handle, what are they doing to my specimens, why is this so different? And the fear is of an inadequate margin related to sampling. So we saw how you could look at this a lot of different ways and come up with 2 centimeter, 2 millimeter, or a positive margin depending on where you took your slices. Now we're not advancing. Now where's backwards, previous? Here, is it me? Look at this. I gave him a specimen, and the radiology technician crushed it with that. This was a 1 centimeter cancer. Look what they did to it. It's not even a centimeter thick. Is that a positive margin? Am I supposed to act on that? This is my resection. It's always perfectly spherical. This is a perfect sphere, the perfect operation. This is what a lot of you probably do. And I have to admit, I've read about this. And so the pathologists were telling me, well, you have, 5 positive margins. So I solved this problem many years ago by taking what I called the true margin, where I knew where it was in the patient. I sample it for them, and I say, this is a true margin, and that's how it now is labeled, because the pathology report then goes to a radiation oncologist or a medical oncologist, and most pathologists will report this as 5 positive margins on the segment, final true margins are negative. So the radiation oncologist knows that I believe I have negative margins no matter what they're saying to me. And it makes a big difference. And it happened, I did this because many, many years ago, I was a young faculty member at UCLA, and a very new technique was introduced from Sweden, fine needle aspiration cytology. And I did my first mastectomy on the basis of cytology, and I got a call, Dr. Giuliano, there's no cancer in the breast. So I lost what rest of my hair, and I ran down there, and I cut up the specimen, I found the cancer, and I was talking to the person who cut it in. It was a medical student. The medical student was taking my margins. So am I going to rely on a lumpectomy where the medical student, which at the university, oftentimes the most junior person prosects the specimen? So I take the margins, I know where they are, and I know where they're positive, and I know what to call them. We heard about tangential or shaved and perpendicular, and this greatly affects your positive margin rate. In Memorial, it doubled when you started to shave them. So you get great differences. This thing is not working, guys, in positive margins. Not working. Next, thank you. Well, does a positive margin mean you have residual disease? Well, if you look at the negative margin, 15% of the time, if it's greater than 2 millimeters, you have residual disease. If it's greater than 9 millimeters, in this study, 13% of the time. So a negative margin does not mean you do not have residual disease. And I actually think this whole margin thing is an illusion, and Holland's work has shown that. There are gaps in tumors, especially in DCIS. So if you looked at gaps between the tumor foci, a third of them, it was less than 5 millimeters, and about 20%, it was greater than 5 millimeters, so you could have 5 millimeter negative margins and still have residual tumor. Mel Silverstein looked at this. He looked at if the margin was involved, there was residual DCIS 76% of the time. If it was clear, there was residual DCIS 43% of the time. So it doesn't guarantee that these are negative margins. And now what about oncoplastic surgery? You got to love that. You can take a lot more tissue, and it adds to the oncologic safety of breast conserving therapy because a larger volume of breast tissue can be abscised, blah, blah, blah. Just because we can do it doesn't mean we should. Is it really better? Well, here's an interesting study. 30 patients got a quadrantectomy in Milan, and 30 patients got oncoplastic procedure, these various procedures, and 90% of them had a second operation, so the surgeons love it. And let's go to next. Use that thing. So they found more margins were greater than 2 millimeters with oncoplastic surgery, but there was no difference in the percent of positive margins, and the average margin width was no different. Okay. They excised more tissue and gained nothing in terms of margins, but they got 2 operations. 90% of the patients got 2 operations. So even if it's true, the assertion that large resections increase the width of surgical margins may not add to the therapeutic benefit of a simple lumpectomy. Margin status, as we heard, is only one factor to consider when evaluating local recurrence. Thank you. I have great help up here. If you look at age, younger women do worse than older women. A lot of DCIS does worse. Systemic therapy decreases positive margin. Okay. What about local recurrence? Does the margin width correlate with local recurrence? Well, up to a millimeter in this study, a fairly large study of 400 or 500 patients. Under a millimeter, they had 7% local recurrence. Greater than 5 millimeters, they had 12% local recurrence. If it was negative when they re-excised, no residual tumor, they had 8%. So where's the correlation here? I don't get it. I see no correlation between margin width and local recurrence. Next. Here's another one. Look at these local recurrence rates. 1 millimeter, 2 millimeters, 3 millimeters. They're all quite low. Next. Another study. Widely negative, 7% local recurrence. Close, 4%. Unknown. I guess we should try for close margins at Duke. Next. DCIS. Is all the tumor removed with a centimeter margin? Mel did this. So if you have centimeter margins, you would expect 0 recurrence rate if you remove all the tumor. 14% recurrence rate without radiation. So 1 centimeter margin does not assure that you have that you have no residual tumor. Next. Also, is it a little tiny focus, 1 or 2 cells at one margin, or do you have a large area, a centimeter and a half, where the tumor butts the margin? Because the extent of positivity affects the local recurrence rate. If you have a negative margin greater than a millimeter, it was 7%. If you had focally positive or extensively positive, it goes way up. But of course, if you add systemic therapy, the recurrence rate comes down. Next. Lobular carcinoma, it's hard to feel intraoperatively. It's hard to define the margin width for the pathologist because of the single cell infiltration, and negative margins are harder to achieve in larger tumors and easier to achieve in older women with fatty breasts. Next. Again, though, if you look at the recurrence rate, greater than 10 millimeters, 3.7, less than 10 millimeters, 4.6, involved, 3.1. In Milan, you want them involved. Next. In-breast recurrence is tremendously affected by adjuvant systemic therapy. Thank you, Terry. If you look at these two prospective randomized studies, no adjuvant systemic therapy compared to adjuvant systemic therapy, the local recurrence rate about half as much if you use adjuvant systemic therapy, whether it's chemotherapy or hormonal therapy. Next. If you looked at that meta-analysis that Dr. Schnitzto, there were 21 studies, nearly 15,000 patients, all got breast-conserving surgery and radiation, minimum follow-up at 4 years, extraordinary complicated statistical models that I don't understand. Next. But I understood their results quite well. Local recurrence increases with follow-up time. The longer you follow the patients, the more likely you have a local recurrence. It increases if the margins are positive, that is, tumor is transected, but does not decrease with wider margins. The width of the margin does not decrease local recurrence. Next slide. A lot of factors decrease local recurrence we've seen in this presentation, and Dr. Schnitz's age, tumor size, et cetera, but not width of negative margins. Next. These are the randomized trials that showed breast-conserving therapy works. And I think we actually have level 1 data, prospective randomized data on the width of negative margins. Next. Let's look at how they defined negative margins, or how they defined the margins in the prospective randomized study upon which we all base the use of breast-conserving therapy. B06, no tumor on ink. The NCI, grossly negative. Microscopic could be positive. The Danish study, grossly negative. Microscopic could be positive. EORTC, grossly negative. Microscopic could be positive. Gustave Roussy, 2 centimeters of normal tissue. They didn't state what the micro was. Milan, 2 to 3 centimeters of normal tissue. Microscopic could be positive. So these are the studies upon which we base our use of breast-conserving therapy and look at those margins. Prospective randomized trials, level 1 data. Next. So I think the facts are very clear. Residual tumor is common after breast-conserving therapy, regardless of the width of your margin. The presence of residual tumor does not correlate with local recurrence. Margin width does not correlate with local recurrence. Radiation and systemic therapy decrease local recurrence. A surgical margin with tumor not touching ink does not guarantee the absence of residual tumor, but predicts that the residual tumor burden is low enough to be controlled by radiation and systemic therapy. Next. The end game, ladies and gentlemen, is not the amount of residual tumor, but is to avoid a local recurrence. Tumor not touching ink is an adequate margin to assure extremely low local recurrence rate and does not require re-excision. Thank you.